oral pathology, oral medicine, or oral surgery professional who's curious about or even hassled with the complexities of our interdisciplinary work? If yes, stay on for the live stream discussion on navigating the triple O intersection. Hi, I'm Dr. Mandana Donahue, founder director of Oral Pathology 360, where we promote the diagnostic sciences of dentistry to education, awareness, and collaboration. But before we get on with today's discussion, let me share some news and relevant information with you first. First, the dates for our annual conference, the International Oral Diseases Case Presentation Conference 2023, is out. We are joining with our global partners to make it even bigger and better. And you should definitely save the dates. If you were not there last year, this video will give you an idea of what you missed. Now, the format for this year's event also will be the same, but definitely there will be improvements. So, poster presenters will have a chance to present a short video summary, and we will have a compilation of the complete proceedings, which will be published as a book, besides the abstract collection. We'll also be awarding some students free registrations, besides the giveaways, which we have every time for our events. I hope you'll be starting to look for your cases, and I hope you will join us. To find more and stay updated, do please visit our website. That's www.oralpathology360.com and check the conferences section. Everything will be updated there as and when it happens. Now, on other news, you have probably already seen and hopefully enjoyed solving our weekly word puzzles, but we have two new features for the same. The first and foremost is that now you can submit your puzzle, and that will be published with, of course, acknowledging your name. And check out the contributions tab in the website. And there in the bottom of the page, you will find a possibility of contributing, submitting a crossword or a word puzzle. The second news we have in relation to this is that if you're among the first five people who solve any week's puzzle, and send us a screenshot of the same, we will acknowledge the name of those who are among the first in the subsequent week's puzzle. And the link for this will be available each week from now. So you can look at the end of each puzzle to find the link for submitting your answers or the screenshot of your answers. I seriously hope you will enjoy this. Also, do let us know what you think of this and how else we can make learning fun. Now, coming to today's talk, very vital discussion that we are having, and I'm very glad to say for this, we are joined by three eminent and dedicated colleagues from the three departments. First is Dr. Shesha Prasad. He is a highly accomplished dental professional holding a Master of Dental Surgery, a PhD, MFDS, and RCPS. degrees. He currently serves as medical superintendent of Sri Krishna Sevashrama and head of the dental department. He is also the proprietor of Yashas Dental Healthcare and a senior lecturer in oral medicine and radiology at the Oxford Dental College. We also have with us Dr. Kaushik Pai, who's a highly skilled oral and maxillofacial surgeon. He has also received a fellowship in the craniofacial surgery besides his master's in the subject. He's a consultant for craniomaxillofacial surgery and implantology at multiple hospitals and takes pride in providing quality care to his patients. And last but definitely not the least, the oral pathologist in the mix is Dr. Padrana. He is a dedicated oral pathologist and microbiologist. Many of you may have seen his posts across the social media platforms. He holds a master's in the subject. He is currently the chief clinician and partner at Adi's Dentalaya, a multi specialty oral and dental clinic. He is also a consultant oral pathologist, co director, and co founder of 91 Danta Research and Product Development Private Limited. Welcome to all of you all. So now let's begin with the discussions. Yes. Right. It's wonderful to have you all here. And, to begin with today, as we were starting and as we were waiting to start, I was told by all three of them of how good a relation they have and how much they enjoy working with each other. And that's essentially what we are hoping to achieve at the end of today. We do realize that there are difficulties sometimes, but they are not rare and they are not unique to us. This is just going to be the beginning of a conversation so that we can hopefully look for the next future generations who can work much better with each other across the board and for everybody. So, again, let me say welcome. And anything any of you want to say before we start?
Thank you for this opportunity, ma'am. It's really a wonderful thing to be on stage with my colleagues and an esteemed person like you. It's a privilege and we really honor it. Thank you so much.
Thank you. The honor is ours. Thank you so
Thank
much.
you.
Same here, ma'am. Thank you for the opportunity.
Thanks a lot, man.
So you're most welcome. I'm really happy to have you all here. So there is just one thing I need to ask. I don't know if like, can anyone who is on Facebook tell me that Facebook is working fine? Because Facebook, checking the scene is a lot more complex than the YouTube. So if you can just put in a comment, I can see the comments though. So that would be very nice. And then let's go on and let's start. So I think we just thought that we'll start the discussion with the parts where we are most likely to have difficulties. And among those, I guess the one of the very first things is where we have, you know um, what I would say is boundaries that sort of cross over each other. So let's hear your views on the boundaries that we have, because obviously there are boundaries between oral pathology and oral medicine that sort of meet and cross each other. There are boundaries also between oral medicine and oral surgery with the surgical and the non surgical treatment, but where again there is some amount of overlap. So let's start with that. I just kind of throw the ball at Dr. Shesha Prasad and let him start.
Um, I would say that we are like a nation with a bordering states where we have these common boundaries. I mean, there are certain areas of intersections where even we see even in the national media that they claim that this is our states and this is my state, and I mean something similar on a smaller scale, I would say. When it comes to my subject and my purview, I think oral medicine and radiology is all about clinical diagnosis. Now, our boundary ideally should stop at the clinical diagnosis, and anything beyond that, I would say, should come either to the treatment part, goes to the surgical part of it, or the The main diagnosis goes to the histopathological diagnosis goes to the oral pathology department. I would say we should strictly confine our boundary to clinical diagnosis and leave the rest to the other specialities, so that all of us can really work in tandem and come up with a patient centric result. This is what I have to say, man.
Are
Ma'am, we are
you
unable to
hearing,
hear
ma'am?
you.
Yes, I put I was, yeah, okay. So the that's very well spoken and very well said. Definitely that is where the lines should end, of course. And let's hear also what the others have to say, and then we'll take it a little more. So who wants to go next? Let's take Dr. Kaushik, I guess, so the oral surgeon can go next.
Good afternoon, ma'am. Uh, I would like to start by saying that in this topic, I think my boundaries are well defined. Uh, the intersection between oral medicine and oral pathology is more intervening than oral surgery per se. So there might be a lot of overlapping between oral medicine and oral pathology. But as far as it comes to surgical part, we usually constrain ourselves to doing the surgical treatment of whatever it's necessary, whether it's diagnostic or treatment execution of the final treatment. So major overlap mainly comes in the uh, pre-malignant diseases and some cysts where there is a overlap between, especially in borderline cases where you cannot decide whether you have to go for non-surgical or surgical. In that aspect, I think it is better to communicate better and get the panel experts together, have a case discussion like we have on in tumor boards, and go ahead with the treatment.
Okay, Dr. Abhishek.
Yeah, I'd be slightly disagree with both of them. Like, yeah, it is overlapping, but there is, as such, we have an undergraduate degree, like BDS we have done. So sometimes, unlike a general pathologist, what happens, they're confined to their chambers most of the times. In oral pathology, what we have the fortunate this one, that we can have a look at the patient. So, if we, with the right training, we can perform a biopsy. With the right training and support of our colleagues, we can help the patient with certain medical management, as oral medicine specialists do. So somewhere, um, yeah, boundaries will be there. Like, in the sense, I'm going as an oral pathologist and doing a we don't do justice by doing improper biopsy and not giving the right report, and somewhere putting on wrong kind of a plan. So that should be our on onus of the individual. So somewhere the boundaries are hazy, but for us to do effectively, if we can have a team that can intervene, and we have a surgeon performing the right biopsy and medical management, and further, so I feel it is like a Ganga, Jamuna, Saraswati. Somewhere we form and then we flow to the ocean. Ocean is finally the patient care. So maybe Saraswati, they say that it is an unknown thing that flows. It's in somewhere in between. It's called Gupta Gamini, somewhere inside this one. Uh, so these two rivers are seen. So finally, patient should fit. So in that sense, boundaries are easy. I agree with partially to Ushi, but not that we should not do that. As and somewhere the training of undergraduation in oral pathology is little less, where it is just spotters that are there, and uh, in that sense, it is a little restrictive. Them practicing oral pathology. Somewhere that freedom BDS has given us, where if we learn a technique of biopsy, do it properly, we can do it in that sense. But justify we should justify we doing it. Recently I tried to do an intraosseous one. I did find a lot of challenge, and I thought I should have taken Kaushik along with me to justify this to the patient. I took a lot of time. So in that sense, yes, those boundaries in terms of patient care will definitely mean a lot. If we draw on like this, I can't do this, I can do, that we should draw ourselves like oral pathologists. Sometimes if we do both medical management and the biopsies, if you're good at it, well, go ahead.
Okay, let me just ask our audience, please start putting your opinions also, because this is more a conversation, it's not a lecture. So we will take your suggestions, your comments as they come along. Now, I have, coming back to the discussion, I am going to be the devil's advocate here. So, as a devil's advocate, I have to ask this. First and foremost, is, I think one thing we need to remember is that practice, probably in a clinical practice that's not in a college, is very different from a practice that is within the college. I think that's something first we have to divide the two. So, in a college, for example, we have very clear cut departments and everybody is available and everybody does their own thing, obviously. But for example, in clinical practice, now, Abhishek, you were saying that as oral pathologists, we have a little more chance to see the patient than, say, general pathologists. I don't think in a clinical practice that of oral pathology that would necessarily be true. If people are sending you samples, they will still just send you the biopsy. They're not going to send you the patient along with the biopsy. So that again is, that's the thing, unless you yourself are treating the patient. So that is one thing. But nonetheless, we do need to see the patient. And that's, I think, one of the points where we have a problem is when we actually need to clinically see the patient and maybe the patient is not available. And I think this problem is more noticeable when we are in the college and, the patient is just in another a department away. And if we don't get access, obviously it's upsetting. So, but practically, again speaking, if we were practicing outside, I don't think every time I would be able to get a patient. These are realities of life. Then on the other hand, when we come to biopsy, who should or should not take a biopsy? you know this is one thing that I have always found. Obviously, yes, we can all do it. But best case scenario, if you are the only dentist in some, boondog kind of a place, obviously take the biopsy, do whatever you can, because there is nobody else to do it. But what if you are in the middle of a city where everybody is there? There are, dozens of oral surgeons, oral medicine, oral pathologists, everybody is there. So there, what do you do? What do you all think? Who should? Because unless we are going to accept that there are points where there is disagreement, we will never get past them. It's a friendly discussion. Luckily, all three of you are already fairly in good terms, so I'm not going to cause a fight there. But this is something we need to address. So let's address this. Who should be, when we talk about boundaries, one of those? Who should take the biopsy? Who should perform the biopsy?
Okay. Can I go first, ma'am?
Yes?
Yeah. Uh, Very interesting two questions, two interesting topics brought up by Mandana ma'am. So, as far as the first thing is concerned, that it is very difficult to get hold of the patients in a private practice compared to college practice. Definitely agree. Uh, but that's where I think the advances in technology and digital age has come for a rescue. So, and as soon as we get a patient, I think it is the duty of the every clinician, be it practitioner or a non-practitioner, every department for that matter, is documentation. If you document the case and the presentation properly, I think uh, half of our issue of not seeing the patient clinically is solved. So nowadays we share all the files or the clinical pictures as well as case history and all via WhatsApp in a crude way. And if at all needed, we share also the radiographs as well as CT and MRIs through Dropbox or cloud storage. So that is where I think this technology bridges that clinical gap in our practice to be on a coming to this age. So second question is, and sometimes luckily we have had few patients who were willing to come down to the specialty practice of Dr. Abhishek when I requested them, because as a surgeon you should know your limitations as to what you can do, what you cannot do. There might be certain signs or symptoms which I might miss, and Dr. Abhishek or Dr. Shesha Prasad might catch it. So I think having three eyes is better than having one. So, as a clinician, you tend to restrict yourself to what you have seen or what you have read. So, if you have three experts looking at it in their perspective, probably their experience or academics might help in getting a diagnosis better and faster. For example, if there is a case of varicose CA where extensive varicose CA, just an example I'm telling. So we had one extensive varicose CA last year. I remember we had done a biopsy, but it didn't look like a simple varicose CA. It was a long-standing 7 8 years. So I had sent the images and scans to Dr. Abhishek. So still the radiologist said ki the nodes were inflammatory, but we just went ahead and did the neck dissection also. Luckily, the nodes turned out to be malignant, and there was in the final pathology, one or two spots there were squamous cell islands into the connective tissue also that way. So that's what Dr. Abhishek helped me to get it right, saying that you rather over treat the patient than under treat him. So that is where I mean to see that when you discuss the case properly, I think the outcome for the patient is always better. So that's just one example. Second example, as you said, who should do a biopsy? I think doesn't matter, ma'am. If we are well trained in the basic art of biopsy, so this is one area which is common to all of us, not just oral pathology, oral medicine, oral surgery. Even a well-trained BDCS general practitioner or BDS practitioner, if he or she is confident enough in managing to get adequate tissue, if she can uh, judge the margins where all biopsies need to be taken, because sometimes in erythroleukoplakia and some other lesions, so one boundary might be completely different to what the other boundary might be. So in which case you need multiple biopsies. If they can assess the lesion correctly, assess the margins correctly, assess the depth correctly, and get it right. And if they're fairly well trained enough to manage the complications like bleeding or tissue closure or suturing or closure without having any adverse effect, I think everybody has an equal right to do. There's no separate justification or SOP needed to put it in place that no biopsies have to be done by only an oral surgeon, or for that matter only an oral medicine expert or an oral pathology expert. Because in towns or big cities you have enough expertise at hand who can come and do. But as you said, as we go towards tier 2 tier 3 cities or in rural side, when you only have a general practitioner, a good enough practitioner is who is well trained, is well capable of doing a biopsy, can handle the case well, and I think they will do justice to the patient. That is my
Right.
point of view.
Okay. Dr. Prasad, you want to add anything? A little short. We have some comments from the audience also.
Actually, I agree with Dr. Kaushik. I mean, the whole perspective is give adequate, relevant sample to the oral pathologist. That is what should be our aim. Now, many a times I have consulted oral surgeons when I have performed a biopsy, or I have consulted Dr. Abhishek, to ask him which areas he would like to me to take a biopsy. Now, I think if that is a teamwork backstage, so that we are well prepared to understand what is the goal and what we need to do. Though as rightfully Dr. Kaushik said, anybody can do it with a proper expertise and experience, but a little collective discussion as to how to go about before doing the procedure would, would be thoroughly helpful. That's what I feel. So anybody can do it, yes, but it has to be done right. That is the whole point.
Yes, that's the whole point. So let's see. Now we have Dr. Dipanshu Agarwal is saying nowadays clinicians are not taking the biopsy but going ahead with the medication. What to do in that scenario? Any thoughts on that?
It depends, Dr. Dipenshu, it depends on what kind of disease or what kind of lesion we are looking at. Now, if we are definitive about a lesion and we don't warrant a biopsy for such lesions, then what you're telling is perfectly agreeable. But if there is an element of doubt and you feel that biopsy is mandatory and clinically it is not conclusive, then I think we should go ahead with a biopsy.
I think he was basically also talking about OPMDs. So, yes, this he put in afterwards. And yes, Dr. Nandini is saying specially lichen planners and also. Right. So, we have another one on the same thought as Dr. Likita also is basically saying the same thing. If you're confident, go ahead and do it. Otherwise, then we can go ahead with biopsy or minor treatment. If not, better to call the specialist for help. That is, of course, always the case. Now, a very short touch on this from the three of you or anyone out there. What about any time? Like I said, I'm playing the devil's advocate today. So, what about any time where during your career, I'm not talking about where you are today, right? During your career, where this whole system did not work? Have you come across a situation where it was not working and then did you manage to get past it? Maybe yourselves, maybe the departments you worked or the departments you studied.
Uh, who has to do the biopsy? That was the thing, ma'am.
No, basically, where you don't really, it's we went past the biopsy part. Now is the fact that the three departments you have to interact and guide each other, and then whatever it is, the outcome will be better. So, have you ever had a situation where that did not work, where the guidance was not there or was not accepted, or maybe there was disagreement? And then, could you reach a way of, or did you find, or did somebody find a way of overcoming it?
Yes, ma'am. Many a times, actually, during my post graduation, there were some lesions which were looking very typical, and our professors would say that, this is what it is. The final diagnosis is most likely this. But there have been times where, as a student, I have disagreed, and it has also proven right, because when we did a biopsy, the lesion did not look as it used to be. Clinically, what it was diagnosed was completely different from what report we came across. So I think we have, all of us, I think Dr. Abhishek and Kaushik also agrees with me, that during our formative days or during our learning days, we have come across many such situations where something has been forced upon you and things may not be the same. It could also be vice versa, that you would be definitely very sure of some diagnosis, and then you tend to disagree with your teachers, and then they are right. So it could be both ways. So we have encountered, I think both of all the panelists will agree with me here.
All right. Anyone else wants to say anything?
Like ma'am was telling, interdepartmental something has happened like that. Yeah, it has happened. We have rubbed our shoulders in friction and sometimes smoothly, and I feel this does not happen in private practice, right? Because what happens here is the patient becomes the center, whereas in the college there is some ego trip that is happening between all the three departments, and yeah, we are guilty of that. Definitely, oral pathology departments, and shying away from giving photographs, and all that we have also done. Like as a department, I can say that. But I feel trust. Trust is the one thing that uh, it should be created more, where it should come from the head to the bottom. So these things happen when there is an open discussion, and people don't go behind the credit, but go behind treating the patient or creating an excellence hospital or patient care. I feel these will become secondary. That's what I feel. And first question I didn't get an answer, small answer. When we go for a consultation, if patient can't afford a lot of specialists, sometimes you go as an oral medicine specialist, you tend to do the biopsy because patient can't afford like calling another surgeon again another consultation. So economic constraints become a problem when we have to work ideally. Whereas in college it's not like that. So that was one point I wanted. So there is a friction, ma'am. I feel in college ego trips are there. In private practice, patient and that becomes
Yes,
the center
I agree there
dogma
are
where
ego
we
trips,
do a
but do
good
you think,
justice.
can we decide what the ego trip is about?
Um, let's say that I have a patient who is definitive. I am sure that the patient has oral submucous fibrosis. Now, I still want to go ahead and confirm, and I send a biopsy sample. Now, there is a whole lot of debate as to whether you should do a biopsy in submucous fibrosis or you should not do. The debate starts from there, ma'am.
From both
And we
sides.
still go ahead, and the people there say that no, yes, no, yes. Finally, you end up with a biopsy. Then you finally send it to our oral pathology colleague, and he says there is no OSMF at all. Now, here the problem starts. Now, clinically, you are sure that there is fibrosis in the patient's mouth, and the patient has trismus, he's unable to open his mouth, but your colleague says there's absolutely no fibrosis, and things are fine. Now, I think this is a small spark which starts off and say that I have a point to prove that I am right, and he has a point to prove that he is right.
Very true. That does happen. And
Yeah.
what do you think would be the way forward?
I would say that we should definitely leave our egos and agree to think a little outside the box or inside the box, I would say. It's better that both the clinicians sit together with the patient, examine, see what is there, what we see. Seeing is believing. And then, of course, one of us have to be wrong, accept it gracefully, and go ahead so that we accept this as a learning process and nothing else.
True.
I think that's the best way to do it.
Yes. How open would, say, and since we took the example now, and I'm not trying to say, of course, right now I'm trying to be as unbiased as possible. I know I'm an oral pathologist. I'm keeping that out of the mixture. But the only thing is, how open do you think, or how practical do you think it would be if the oral pathologist said, "Please come, I will show you under the microscope and explain to you."
Yeah, it is a welcome gesture. Definitely, yes, we should go. One point is having a clinical discussion with the patient. The second point is also go to the department, see what is
Yes,
happening under the microscope. So both ways
correct.
it helps.
Yes, it does. And I think every time I have worked with people that I could work very well with, and I have worked in six different institutes, some with exceptional, graceful and good interactions, some not so much. But the point is, I've always found where both sides were ready to go that one step, you know. Okay, once I'll come to your department, next time you come to my department. We sit and discuss it. Finally, like you said, it's all about the patient. So this I agree. I think sometimes, yes, of course, two people cannot be both right about exactly the same patient. True that sometimes histology is, you say that this tissue, this specific section is not showing. That can happen, but maybe not in something like oral submucous fibrosis, which is widespread. But the thing is, in the long
And
run, so this is
maybe
one thing that I agree with you, is that everyone has to agree to meet in a middle point. Another thing, I don't know, I think that one particular reason that in the institutes we have a problem rather than outside is that selfishness about patients' data. Everybody feels they own the data, you know. My diagnosis, my pictures, my x-ray, my histology, my nobody wants to share. It's like mine, that is that. If you ever watch that movie Lord of the Rings, that mine, we begin to feel like that. It's
Ma'am,
like
you
that
left out a
magic.
very important aspect. My
Yes, tell
publication.
me.
Exactly. I was coming
Yes,
to that.
you see, my data eventually becomes my publication.
Publication, correct.
But people should realize that as we go up the ladder, your name also should go back. You should
Correct.
not be the first author at
True.
all.
True.
You should be the
Very true.
third or fourth or fifth author, which speaks high about you. Most of the people don't realize that. Do you agree with me, Abhishek?
Yes.
So,
Absolutely. What
if
happens
we
is,
realize that, I think we can not be so selfish about the data.
True.
It's
And
all about
actually, with
communication.
seniority, the very fact is that it's taken for granted that seniors are further down in the list of publishers, unless it's a research and it's their own personal research,
Correct,
where they're
correct.
heading the research. Okay, let's see what our audience has to say. There is Dr. Chaitanya Babu is saying many times surgeons would have done treatment thinking it could be a benign condition, but it could turn out to be malignant. Yes, well, that is,
Very true, very true. I
I
just gave an
think,
example where we had an extensive varicose CA,
yes.
which we consulted, and Dr. Abhishek said better to overtreat the patient than to undertreat. Luckily for the patient and for us, the lymph node, which was supposed to be inflammatory, turned out to be malignant, and there were keratin pearls in the connective tissue. So you rather sit with your oral medicine and oral pathology colleagues, discuss the case, communicate better. I think communication is the key to better understanding and giving better treatment outcomes for the patient. So if you communicate well, you have a good team with a good mindset where you all mingle and communicate well with the patient. I think the treatment outcome will be always ideal for the patient.
Now, I would
True.
like to quote one more example with Dr. Chaitanya here. We had a case very recently, which it was a ulceroproliferative lesion. The patient had a fixed kind of a denture with some quack, wherein the acrylic was pasted into the mouth, and then that was removed, and there was a huge lesion after that. So we were very, very sure clinically that this is malignancy. So what we did is when we took a biopsy, to our surprise, it was just a chronic inflammatory lesion and no malignancy at all. In fact, we took a second opinion from one more pathologist who also confirmed the same. So I would I would feel, I mean, it's a personal opinion that if we have even a slightest element of doubt, we should go ahead with biopsy.
True.
The only harm we are doing is removing a small piece of tissue, we are inducing some pain to the patient. But in the broader spectrum of things, it is always beneficial to the patient. Always.
Very true. Yes, correct. Very true.
I'll add to Dr. Chaitanya's question, man. If a benign lesion becomes malignant, there should be a thing that surgeon should go back to the patient, say we need another surgery to be done, where the margins had to be readdressed. So that honesty, if a clinician has, where yeah, this thing has happened, we have to correct it again. Uh, then what happens here, no ma'am? The patient also wants us to look at the doctors to be perfectionist, where they should not make any mistakes. So somewhere that patient has created that the ideal scenario where once the surgery is done, most ideal thing is going to happen. So the surgeon, if at all there is a malignancy, he has to go and revise it, ma'am. That and the oral pathologist has to put it on the paper that this is it
I
and
think
this has
there's
to
no
be
question
revised.
that that will be revised because I would think not revising that falls well beyond the realms of ethics and legal, sort of duties that we have. So that is not going to be a question, but it would be a problem. Actually, Dr. Chaitanya also has a follow-up example he has given where it's talking about not really a malignancy in that way, but for example, a periapical lesion, if it's treated as a cyst and then turns out to be a malignant tumor. So these are definitely
Yeah, these can happen. I mean,
problems. These can
we are also
happen, and
humans. Yes.
yes, there is no question. If you also consider, one of the things that Dr. Daftari, he's a very well-known oral pathologist. What he always says and what he always insists: do not just extract a loose tooth. You got to know why it is loose. A
Agreed.
mobile tooth is not mobile just unless you find that okay, it is in keeping with the age of the patient, the overall condition of the teeth, everything. But if all everything else is fine and two teeth are suddenly mobile, it you got to be wondering why, and so this but these things happen. I mean, we keep saying, but they do happen. And at some point, I guess our training will have to improve before the number of such mistakes reduces.
It's a very
So
simple, sorry to interrupt, a very simple
no, please.
this thing. Just to take an X-ray of the involved teeth, I think that will solve most of the issues, especially for maxillary posterior teeth. I see many nasopharyngeal carcinomas involving the maxillary posteriors. Just the practitioners, without taking an X-ray, without checking the bone support, I think go ahead for extraction, and the patient in turn blame them for having a carcinoma diagnosis later on, saying that the doctor extracted the teeth and that's why it has happened.
Yes.
So all such mistakes, I think we can avoid via simple diagnostics.
Yes, absolutely. Actually, and I think they are again where if you are practicing what I would say proper dentistry, actually they are essentials.
Yeah,
They are not really a luxury; they are needed. So
needed,
yeah,
correct.
yeah, that is there. So I think we
And
have
can I add a small point, ma'am,
yes,
on this? If at all you
yes,
periapical
please go
some
ahead.
tissue
I'm
has
just
been
looking at the
removed,
questions here. Yeah.
if the tissue has been removed, better to submit for histopath. Even though you have non-vitality there and everything,
Yes.
get a histopath report done.
Yeah, we
Yes.
should. I agree. As a clinician, we don't
Yes.
do it routinely. I totally agree. We just discard that tissue. It's. I think we should make it a habit to send it for histopathological examination. There's nothing to lose.
Yes. When we were studying general surgery, we had this teacher who used to say, it is a rule. If you remove anything from the body, it has to go for a pathology exam. If you remove it, you have to examine it. Otherwise, don't remove it. He had this rule. I don't care what was the cause. If you cut it out, you send it for pathology. So, yeah,
But I think in Indian scenario, finance plays a vital role, and
yes,
thanks to Dr. Abhishek, many cases he does histopathological examination for free of charge for the benefit of the patient.
true. So, of course, our audience is saying patients should be the center. I have a question that I'm not entirely sure. Dr. Rajshekhar had first said if we have a doubt but still no proper, or still in confusion regarding the oral pathologist report, valid or not. I'm not quite sure what that's supposed to be.
No,
Any of
I
you have
understood
anything to
that, ma'am.
say?
Uh, I feel if he's not sure of the report, he feels it is something else, and the report is saying something else.
Oh,
We have
okay.
always option of requesting the block and the
Right.
slide
No, okay.
from the oral
Sorry. There
pathologist.
seems to be a follow up to that, which says some hospitals only consider general pathologist. What I mean, I guess what he means is that why is the oral pathology report not as valid? I don't necessarily think that is true. If it's a oral and maxillofacial lesion, I think
No,
our
I think what he implies is when you give these oral biopsy samples to some general pathologists, we may have some varied reports. We may
Correct.
not get the diagnosis what we are expecting because I've undergone that
Yes.
many a times. So when you are giving it to your general pathology friend, I think first we have to educate our friend, tell the background at what we are looking at, and then give the report. Now, if we are not
very
doing
true.
that, then I mean, there is definitely going to be a bias because they don't have so much of exposure in looking at these things which we are commonly encountering.
Yes,
So I think that's what
very true.
the doctor means.
Like,
Yes, you're most likely right.
like
Okay, we have
recent
one from
example,
Dr.
ma'am.
Mayondi. Sorry, yeah.
Example where Dr. Kaushik referred a verrucous carcinoma to the patient actually came to the clinic to show it. So he has got it done from a very like a well-known hospital, and the report was no malignancy. That was the report what they had given. But when I looked in the mouth, it's like proper 6 centimeter. It's from the retromolar trigone to the commissure of the lip. It was a verrucous carcinoma. So I had to write what is verrucous carcinoma and then send the report back. So it does happen when general pathologists don't come across lesions, and somewhere oral cavity is a special place where the clinical imports is very very important compared to a general pathologist. So Rajashikar, if you're working with a general pathologist, as Prasad sir told, educate them, send them the photographs completely, send them all the diagnostics that are there. So they will see the gravity of the lesion there. So that time maybe it's better, and start developing a relation with an oral pathologist. Maybe you'll get better reports.
Very definitely. So we have Dr. Mayandi who says the way forward, of course, is a multidisciplinary approach without looking down on each other. I think um, that's of course the gold standard at the end. So then, of course, Dr. Nandini, I think, is talking about the publications. Then Dr. Aruna says collaboration of healthcare workers right from first level of contact with patients should be the essence towards precision management of precancer and cancer. I think towards precision management of almost anything, I would say
Anything.
actually that would be. Yes. Okay. Right. So since we are having one old issue, which is that, that typically even olden days, there used to be one where uh, people would take out a biopsy, send half to general pathologists, half to oral pathology. It was almost like comparing, but I think that has now reduced. I don't really think that happens
No,
anymore.
no, ma'am. I must admit that it is exactly opposite with me. I don't trust general pathologist diagnosis anymore. Let's make sure I get one part of the sample biopsy to Dr. Abhishek. And I think in
Same here,
many of
ma'am.
the cases, the diagnosis turned out to be completely different. Remember one case we have the general pathologist had given as a dental cyst. I don't know what diagnosis that is. Turned out to be a unicystic ameloblastoma at the end.
Right.
I agree with Dr.
Okay.
Kaushik.
True. Times are changing. We have to accept that times are changing. Yes. And okay, we have a question from Dr. Dipanshu, but it is really out of today's discussion, so we will leave it at the moment. If we have time, we'll come back to it. Dr. Chaitanya says that most likely Dr. Rajshekar is asking whether oral pathologists can sign a histopathology report. Well, the answer to that also is that yes, we can, as long as it's an oral and maxillofacial lesion. Definitely, we can. And okay, this is from, yes, Dr. Vivek, who says that whenever there's an oral pathologist during the biopsy, it does help. It definitely does. Okay, I think we are going to run out of time. So we got to jump very quickly to our second point. I believe we were, initially we had thought of doing, what was it, dependencies and boundaries, overlapping boundaries, and expectations. But I think dependencies sort of got covered in the boundaries part, because where we depend on each other for a report and, for tissue or for images, for so many things. And obviously, if one of us is waiting, sort of at the edge of our chair and waiting, and then there is delay, obviously there is going to be, tensions are going to run high. But another thing I would say, and now since the three of you are working well together, so I'm going to ask you this: what about expectations? Do you think sometimes part of the reason we have problems is because we have expectations which we don't really necessarily tell the other person about? It's not so much a problem of the sciences or the specialities, but the problem of the people, of the individuals involved in those specialities. Like, for example, sometimes when you send a report or you refer a patient and you expect the person to at least give you a call back and say, okay, so and so happened with the patient. But if, say, I'm doing the referring and I don't tell you that, listen, after this happens, please let me know. At least once I should tell you that I would like to be in the loop of what happens to a patient. So unless I tell you that, you would never know. And you may or may not personally decide, to say something or not say anything. Now, in those terms, this was an example. What do you all think in between the work that we do together? Have you ever come across where expectations were not clarified and therefore led to problems?
Not so far, ma'am. In my 23 years of practice, no. I think I go straight ahead and call my colleague and tell him what I'm expecting. Now,
Right.
I've been working with Dr. Abhishek closely, I think, more than 12, 13 years now. We have never had such problems. because if there's anything that he would call me or I would call him. And even when I'm sometimes I have to, I have to, because of the distance or something, I have to give it to a general pathologist from a very reputed lab, SRL laboratories. I just step down and call the pathologist to know what is happening, and I also tell her to tell me that if we are in the right direction. Sometimes even we debate. Sometimes when the report is also given, definitely I disagree, and I tell her that no, this is not what I'm looking for. So I think we should leave all our egos and stop assuming things that the other person would, understand and all that. Go out straightforward and talk to the person in the best
Exactly.
interest of
If
the
there is an
patient.
expectation, go out and say it what
Yes.
it is.
Yes,
Yes.
be very clear
Dr.
about it.
Kaushik, Dr. Abhishek,
True,
anything?
very true, ma'am. I must add to Dr. Shesh Prasad what he said. Usually, if you work as a team and you have a good mindset, same mindset and communication, I think the expectation is intuitive when you're working together as a team for such a long time, so that expectation is well taken care of. This problem initially happens during the first few weeks of working together, like you're a new surgeon to the oral pathologist, or you're a new oral pathologist or any pathologist to a surgeon. I think that building that rapport takes a little time, so that's where this trouble of the expectation comes in. But once the team is well set and it's like a well oiled machine running, I think expectation is well taken care of. And I must add to the point that, as you said before, if you take that one extra step, I think it is justifiable and the results are ideal. Whenever we have had a doubt, so I usually go to Dr. Abhishek's clinic to sit down and have a chat and have a coffee as well. He's kind enough to take me to a coffee shop, and we discuss the cases over coffee, and that's how we sort things out. I mean, that nicotine stimulates some creative ideas, out of the box thinking. Some pathology specimens which are borderline and which Dr. Abhishek has said it needs immunohistochemistry and things like that. We just speak a one round. I usually go to his place or he comes down to my place. We share the clinical pictures and we discuss the case. So I usually end up joking that all I come and do in his place or vice versa is discussing cases only. We don't get time to discuss or go around with other casual stuff.
It's true. I think at the end of the day, what like Dr. Shishwar Sad also said in the beginning, if when you think about it, the combination of an oral pathologist, oral medicine, oral surgery with three different, very different, but very training that then totally completes the picture. And if the three minds and those three abilities get together, there should literally be nothing that we cannot solve for the
Yes,
patient's
very true.
benefit.
Very true.
That is definitely what matters most, really. And yes, sometimes things will go wrong. I always find the easiest is, one of, and I myself will say it, one of the biggest bugbears that most people had before, earlier on, with oral pathology. I know this is no longer the situation now. Most departments and most oral pathologists will also give a report in 3 days. But the thing is, there was this thing of, if it took longer, you had to do additional tests. The simplest thing was pick up the phone and tell the person, okay, listen, I did so and so and so, and now I need to do this and this and this, and therefore you have still not got your report. It is a simple thing. Just pick up the phone. And of course, in today's world, I guess just text,
Yes.
WhatsApp or whatever.
Yes.
Because obviously people are worried, and they would want an answer, and they are answerable to a patient.
Yes.
So, on the one hand, I have to say, as oral pathologists, the one thing we don't do is we don't directly have to answer the patient. And I always, for that, I have the greatest respect for our clinical colleagues, because I know that's the toughest job. We may be the one, who give that diagnosis, but the ones who are going to have to tell the patient what it is. And it can sometimes be, of course, very difficult, life threatening, literally, diagnosis, and you're going to have to give that to the patient. And if on top of that you have to keep telling the patient, no, that we are not sure, there is still no result, I can understand how difficult that could be at your end,
Yes.
and I appreciate that. So, these are the things, but a little bit of understanding, I guess, from everybody can move the wheels around much faster. So
Especially in private practice, the patient's expectation will be quite high because they would already be anxious as well because cancerous or precancerous lesion will be in their mind, on the back of their mind always. So when you tell them ki the pathologist has requested another 2 3 days time to do a immunohistochemistry marker or something, I think that anxiety level goes over the top for some. So that's where I think communication with the patient matters. Tell them that usually it takes 3 to 4 days, and if needed, it might take 1 or 2 more days just for the confirmation.
exactly, it's just the chain of information that needs to
Information,
be.
correct,
Times have changed. The days where you just told people told the patient this is what it is, and with no explanation, those days are way gone. We don't live in that world anymore.
correct.
So we also have to update ourselves accordingly. So, okay, then we have Dr. Raj Sekhar saying nowadays no one thinks in a deep way for case diagnosis, and moreover, patients also not interested to see the case in and out by dentist. I have a pain, just remove it. If we say anything like biopsy or radiography, patient will turn back and go to another clinic. Simply they go and extract this. This is what happens nowadays. Yes, I do realize that's a very practical question. What do you all have to say? You're all clinicians.
Many a times this happens, ma'am, but I still refuse to do the treatment because you have to take a stand. Now, if you have to do an ethical practice, you do it. Now, there are cases wherein the patient even doesn't want to get a blood test done, and I know that the patient is anemic, or the patient has a history of diabetes, or they say that they're perfectly all right, my wound is healing, I don't want to get my blood test done. Then I say, it is your lookout, I am not going to do this. If anybody else wants to do it, it's fine. So I think it takes a lot of courage and maturity to come to this level. But yes, I think we have to do this. Otherwise, we end up in a soup.
I agree with you.
I would add to the point saying that if you try to reason with the patient or educate the patient about his condition, nowadays I think the patient might be more willing to uh, go through the process than getting it done elsewhere. But there will be some who are in hurry or short of time or who may not understand the ideal way to do it. But for them, at least our effort should be to educate them and tell them that this is this and please don't get it done.
No, that will
Some,
definitely be done. We would definitely
yeah,
educate them. But in spite of that, also, if they are reluctant to undergo the
yes, yes,
treatment,
yes,
what my say was, please don't do it if it is
correct,
not the right thing to do.
correct, very
Because
true.
you're
Yes.
trying to help the patient, it's really not helping them actually. It is
Yeah.
going to boomerang and come back to us. And they say,
Yes,
see, you're the
very true.
doctor. We've had such instances also. You should have told me not to do it. Why did you agree to my words? I mean, this has also happened.
Correct.
So,
Okay. So we have a request from Dr. Safa. Dr. Safa, I guess we will, you can look around and we will see if anyone can find content about multiple sclerosis. This would not be the right, get together with us on one of the many platforms where Oral Pathology 360 is there. Send me a message and I will share it from there, and then our community will answer to that. That would be more appropriate. Okay, I think we have reached the end of our time. We have actually gone past the end of our time a little bit. Yeah. So, any closing comments from all of you? We'll keep it short, one sentence each.
let's go together forward.
Excellent. Yes.
Communication and team is the key.
Good. Very good.
Coming together, working together, coming together for patient.
Yes. I think that together is the main team. We have to do it together. Yes, we do. Okay. So with that, let me go ahead and share your certificates. And oops, sorry. Okay, it sort of jumped a little bit. Yes, Dr. Shish Prasad, thank you so much
Thank
for
you so
being
much, ma'am.
here.
Thank you.
Most welcome. And Dr. Pai, thank you so
Thank you, ma'am.
much.
Thanks a lot for having me.
You're most welcome, Dr. Abhishek. And thank you for being here, and thank you with your help with organizing the session. This time, Dr. Abhishek helped me with this session, with the organization. That was very kind and very nice. So, General, thank you for all of it.
Thank you, ma'am. Thank you for the
Thank
Thanks
you
a
so
lot, ma'am.
much, ma'am. Thank you.
You're most welcome. And just a little
opportunity.
information, the picture in your, I will be sending you the PDF of these certificates, and the link to the video is embedded in that. So at any time, you can just click on that and go to the YouTube video of this. So with that, I shall say thank you to our guests, and we will move on to what is happening next week. Right. Thank you. And right. So next week, I have not prepared the picture, but we have one on dental legal aspects of dental practice. So I hope you will be with us. That will be a live stream at the same time, of course. With that, let me say bye to everybody. See you next week. Have a wonderful time, and well, be safe, be well, and practice well.